wanted to review a couple of papers on lepto in light of this recent patient I have named Jinx at Access in LA. The two papers we're going to discuss today, one is looking at two different rapid point of care tests. The other is looking at outcome of lepto dogs that require renal replacement therapy. I'm also going to touch base on a few things from the updated lepto consensus as well. So lepto, as we all know, is caused by the spirochete leptospira. There's lots of different serovars that are classified based on the outer LPS antigen. Most lepto in dogs results from the serovars listed here, including interrogans. I'm not going to say the second one or the last one. We can read and I can't pronounce those, so they are on the slide. Leptospira are shed from renal tubules of infected reservoir hosts, the main one being rodents. They will cause infection of mucous membranes or abraded skin, but we can also see infection from direct contact with reservoir hosts via predation and other modes, including venereal or placental transfer. Once leptospira enters the bloodstream, it's going to very rapidly disseminate throughout the body. It's pretty sneaky in that it can evade innate immune system recognition, defense, and killing mechanisms. And it will invade lots of different host tissues in the body via its corkscrew motion. And the incubation period of lepto is reported to be between 2 to 14 days. Leptospirosis, as we can all appreciate, is going to cause a range of multi-organ effects, the biggest being AKI and hepatic involvement, but we can also see all of these other different body systems that can be affected. Diagnosis of leptospirosis is certainly vital that it's made in a timely fashion, both from improving patient outcome, but also reducing potential for zoonosis. There are multiple tests on the market, the gold standard of which is going to be to culture leptospira, which isn't often feasible. So the practical kind of recommendation is going to be microscopic agglutination testing, which is going to look at our IgM and IgG antibodies, and will collect both acute and convalescent titers. PCR will be another method, either on blood or urine. And then we have two main point of care tests on the market, including the leptosnap test, which will be non-specific antibodies against the membrane protein of leptospira. The other being the leptowitness test, which is testing for IgM against these two specific serovars. The microscopic agglutination test is going to be the standard test for diagnosis of lepto. Anti-leptospiral antibodies are going to be detectable 7 to 10 days after the onset of the disease. So in the early phase of the disease, it will be common to not get a positive titer. So it's recommended to look at our convalescent titers 7 to 14 days later. In terms of a single acute titer, we'll see in about 50% of dogs with lepto, but also potentially something to keep in mind will be vaccines is going to impact potentially titer evaluation as well. To note, the veterinary laboratories will only include about 6 to 7 serovars, whereas human medicine, they have a panel with over 30 different serovars. So MAT testing recommended. Diagnosis can be based on a single positive titer, but it's generally not recommended. It also shouldn't be ruled out based on a single negative test, particularly if the panel includes a limited number of serovars, or if it's a very acute infection. Going on to point of care testing. So the studies we have do certainly have variable sensitivity and specificities reported, and a lot of that's going to stem from the different geographic locations that these studies are performed in which serovars are involved. Both can be affected by recent vaccination. The SNAP lepto test is reported to be positive up to 1 year post-vaccine, whereas the witness test, the data we have shows it's positive in 24% of vaccinated dogs at 12 weeks post-vaccination, but we have limited info after that point. But its specificity is reported to be very high in unvaccinated dogs that have signs consistent with lepto, which is pretty awesome. In terms of on the consensus guidelines, right now it's not recommended to diagnose lepto based off a point of care testing, just because there are limited studies in different geographic locations. So it is still recommended to quantify using the MAT testing. And it's also important to note that with these point of care tests, a negative result is not going to rule out lepto, particularly in our pets that have only recently gotten sick and then present where they might have not had enough time. This is from the consensus as well, and just has a few of the reported sensitivity and specificities of the IDEX SNAP and the Zoetis witness tests. So just kind of here for reference, but we can see that there is only a few different geographic locations that have been assessed. So for me in California, like it's hard to kind of conclude something definitive, like based off the studies we have. PCR done to detect DNA in either blood or urine. It can certainly be negative. Blood and positive blood PCR is going to be diagnostic for lepto if there's consistent clinical signs, because we're not going to see positive blood PCR related to things like vaccination. Ultimately, we can't rule out lepto based off a negative PCR, but if we get a positive, then that helps our case for diagnosing lepto. Other tests are listed here, not generally done due to low sensitivity technical expertise, so are generally not recommended. In terms of defining a clinical criteria for lepto, ultimately there's going to be systemic illness with a combination of different signs from either GI, pulmonary, renal, etc. And then it also will be based off seeing a number of different clinicopathologic abnormalities that are listed here. Confirmation in the updated consensus is going to require a patient to have meeting the clinical criteria as well as supportive laboratory criteria. And then they are confirmed if they meet the clinical criteria and have at least one confirmatory laboratory criteria, which is going to be either based off the fourfold increase in our MAT titers, a positive blood PCR, or isolation of lepto. Treatment going to obviously require antibiotics and then care of the individual organ systems affected. Interventions is going to range based off the severity of cases. So after that introduction, let's kind of move on to the two studies we're going to talk about today. The first being prospective evaluation of rapid point-of-care testing for diagnosis of acute lepto in dogs. And this study came out of Italy in 2018. The aim was to evaluate the diagnostic accuracy of two different rapid point-of-care tests and compare those with the MAT testing. This was a prospective study that was conducted in Italy at the University of Bologna. I don't know if I say that right, but hopefully. So in this study, dogs with suspected acute lepto were included if they had reported exposure to known risk factors, AKI, and or systemic inflammatory response syndrome, as well as evidence of organ dysfunction in at least one other organ other than the kidney. Dogs were excluded if they were vaccinated recently, as this was going to interfere with the MAT testing. Leptospirosis was confirmed either by MAT at the time of admission, convalescent MAT, or PCR on blood or urine. Dogs were then grouped into whether they were a confirmed case of lepto, which was defined in this study as a positive titer over 1 to 800, or a four-fold increase in the convalescent titer, or it could include a positive PCR, and that could either be blood or urine. Negative lepto cases had a negative MAT in both acute and convalescent titers, and also negative PCR. Unconfirmed lepto cases ultimately had an incomplete diagnostic protocol. And then all dogs were evaluated using the rapid point-of-care testing, and then they kind of compared the sensitivity and specificity. The MAT testing was carried out appropriately, and these are the serovars that were included in their panel. DNA was extracted and run based on PCR testing. The two rapid tests they evaluated are the two main ones we have on the market. So the witness test is going to be the rapid diagnostic test A, and then the SNAP test is going to be B, and these are the sensitivity and specificities that are reported by the manufacturers. Moving on to the results, so 89 dogs were included, 87 had a PCR performed, so we could kind of compare those, which was helpful. Out of that group, about half were confirmed cases, 40% were negative, and then about 10% were unconfirmed. Out of our confirmed lepto cases, so 42% had really inadequate vaccination history to conclude. The dogs that were vaccinated, it's important to kind of look at this, that half of those received the bivalent vaccines, which we know might not cover all of the serovars that can cause leptospirosis. And then we can see a very low percentage had the tetravalent vaccine. 88% of dogs had access to an outdoor environment, which, to be honest, is probably just most dogs in the general population. Hard to have a dog that never goes outside, kind of based on how it was defined. Most of the dogs were going to be hospitalized for AKI or SIRS. And then some of the confirmed lepto cases was going to be the dogs that were co-inhabiting, so their sibling had lepto. They were living in the same house and tested positive, but were largely asymptomatic. In terms of how lepto was diagnosed in this group of dogs, so 76% was based off a positive MAT at time of admission, about 10% based on convalescent titers, and then 14% based on a positive PCR. 75% of seropositive dogs did show cross-reactivity between serovars. So we can't typically use the MAT to knuckle down on which serovar caused the infection due to the cross-reactivity. We can see that most dogs that had a positive acute titer was similar when convalescent titers were performed. And we can see 14% of dogs that didn't have an acute titer did undergo seroconversion for diagnosis. Moving on to PCR, so 20% of dogs had a positive PCR, and out of those, about half was on blood and half was on urine. And one dog was on both positive on blood and urine, which is interesting as we don't typically see them come back positive for both. Out of our confirmed lepto cases, they all underwent testing with our witness and SNAP tests. We can see that 71% of dogs were positive on the witness, whereas 78% of dogs were positive on the SNAP test. These are a couple of figures from the paper. So the first is just showing descriptive information from the dogs in the included study. We can see a lot of it somewhat similar between groups. The notable things is going to be our vaccination status. In our negative lepto dogs, there is a higher proportion of dogs that are vaccinated. And then we can see our MAT testing. The top figure is going to be our acute titers, and the bottom is going to be our convalescent titers. And the positive titers are shown in the black color. This figure here is looking at the PCR results, and in terms of if they were positive or negative. So we can see that most of the dogs had a PCR sample performed. There was about, half and half that had blood versus urine positive tests. And they did undergo like a special procedure with the urine where they neutralized it based on pH. And then they also like spun it down to concentrate potential lepto in urine. Out of the lepto negative cases, this was about 40% of all of the dogs. Out of these dogs, 75% had diseases that were mimicking lepto, whereas 25% were asymptomatic, and they were kind of the sibling dogs of dogs that were infected with lepto. We can see that positive MAT titers were detected in 20% of dogs at the time of admission, and then 25% of dogs at the convalescent time point. And the canicola serogroup was most frequently represented. And there is kind of thoughts that kind of could dogs potentially carry this serogroup without being clinical. None of the dogs were positive on PCR if they didn't have lepto. Out of our unconfirmed lepto cases, 12% did have clinical and laboratory findings indicative of acute leptospirosis. Out of these dogs, 36% did have a positive MAT upon admission. 9% had a positive on our witness test. 18% had a positive on the SNAP test. 45% were positive on both of those. and 27% were negative on both of those. And a lot of the dogs that didn't survive, obviously, like couldn't have convalescent MAT testing, seemed to be a proportion of these dogs that were unconfirmed. Looking at the comparison between tests, so the MAT testing had a sensitivity of 76% and a 100% specificity. For our witness test, it was reported to have a 71% sensitivity versus 100% specificity. And then our SNAP test has a higher sensitivity at 78%, and then a lower specificity at 72%. And they didn't find a significant difference between the SNAP and the witness test, but they did find a significant difference between the SNAP test and the MAT testing. I think this is better shown by our receiver operator curve. So to recap this, this line at 45 degrees is going to be like it's as good at detecting lepto as like flipping a coin. So that would be really bad. Ideally, it's going to be kind of high and following this sort of track. So we can see that for our MAT testing, which is kind of the ideal method recommended, is this solid line. The witness test is almost as good as the MAT testing based off this study. And then we can see the IDEX SNAP test is not quite as good based on the receiver operator curve. And looking at this chart here, kind of just demonstrates between the witness and the SNAP, there's that trade-off between sensitivity and specificity. So the SNAP test has a higher sensitivity, like at the expense of specificity. So kind of pros and cons in terms of like what way are we using the test. If it's truly as an initial screening test, the IDEX SNAP test might be better to make sure we catch all of the positives. But if we're trying to see like is a positive result truly a positive, then a higher specificity and the witness test would be what we want to lean towards. Here we can see just a different format that's showing our sensitivities, specificities, and positive and negative predictive values. So we can see here kind of results are shown for the MAT, the witness, the SNAP test, and then PCR. So we can see PCR, for example, really isn't very sensitive. If we get a positive, that is great, but certainly kind of limited to use that alone. In terms of kind of some conclusions on this study, so MAT on acute serum had moderate sensitivity, but pretty high specificity and overall good accuracy. A considerable percentage of animals would have been misdiagnosed if they didn't have a paired sample for convalescent titers and PCR, and that's related to it being early in the phase of lepto. So if you get a negative, you still need to kind of do additional tests to rule it out. This was a European study, and Australis is going to be one of the commonly identified serogroups, which was consistent in this study. And then for our positive PCR results, kind of shows the importance of testing both blood and urine, because it's going to increase our likelihood of getting back a positive. That's going to be typically faster than our convalescent MAT testing. So we don't want to miss that opportunity if we just submit urine, for example. Concluding on the lepto witness test, so it seemed to have in this study pretty optimal performance for rapid in-clinic diagnosis of lepto. The sensitivity, specificity, and area under the curve was almost comparable with the MAT testing. And the high specificity of this test is going to be invaluable for these cases like we do often, particularly for the ones that need dialysis and are severely affected. We do want to know fairly rapidly because that might change the conversation a little bit, not to say it's a reason to proceed or not, but we'll change that conversation. So having a rapid diagnosis is important. For our lepto snap test, so the sensitivity was higher than the other testing methods, but that's going to be at the expense of the specificity. And for both the witness and the lepto snap test, there were similar proportions in vaccinated dogs. Limitations in this study, a couple of main ones to point out, is going to be that the big one in terms of PCR was that most dogs were already on antibiotics when blood or urine was collected. So I think that was a major limitation in comparing these methods to PCR. I think we can effectively compare MAT testing and the rapid point of care tests, but I think that really hampers our ability to interpret the valuable aspect of PCR. As well, some of the urine samples were frozen before PCR was performed, which may have degraded the leptospira DNA. So in conclusion for this first study, the witness was superior to MAT using just the acute titers. This needs to be confirmed in a larger population of dogs and also in different geographic areas. They suggest that the witness test could be used as a first kind of in-clinic screening tool when lepto is suspected, but we do need to take into account vaccination status, previous exposure, or non-specific antibody response. And in conclusion, they kind of advocated that both of the rapid in-clinic tests should be used together, which I thought was interesting. So I want to just take a pause here, and just questions for the group is going to be, are you submitting acute convalescent MATs if you have a positive witness or SNAP test? Specifically, this would be for a patient that has signs that are all consistent with lepto. Are you kind of going ahead and submitting the MAT testing as recommended in the updated consensus? The second question is going to be, are you submitting convalescent MAT testing if you have a positive point of care test, signs consistent with lepto, and the patient is improving? So they're the two kind of discussion points that I think is still a little bit unanswered based off kind of all of the information we have. Some further studies might be needed, but I was curious to see everyone's opinions on these 2 points. I don't have the chat open, by the way.
I said that if there are signs and there's a positive SNAP test, I'll take that. That is good enough for me. Really, we'll do the paired MAT if they're negative on the SNAP. If we have a negative PCR, probably from previous antibiotics, and then we'll look at convalescent titers as our kind of final way to diagnose it. And still, we'll have some patients that we have a strong suspicion that we don't have a test that proves that it's lepto, but they're thrombocytopenic, hyperbilirubinemia, everything checks off, and they just don't have a positive test.
Yeah, makes sense. I like it. And that's typically what I'll do as well. I guess the updated consensus guidelines, they need to cover all their bases in terms of like ideally confirming with it if it's lepto. I find it a little challenging to like justify the extra cost of sending out like convalescent MATs if the patient's walking and talking like lepto. If there's no financial restraints, maybe it's something to consider, but yeah, was curious kind of based on that. So thanks for chiming in, JD. Does anyone else have different opinions before we proceed to the second paper?
I think that RER here doesn't send out the snap test that frequently. My impression that is they mostly just send out a PCR and then send it to me while that's pending.
I would also add, I think if you're, this is Mary Lobato, by the way, I think if you're in an area with a really high prevalence of lepto, which we have, and it varies the serovar from year to year, who's going to be the hot strain. For us, we like to do that convalescent mat to just see what's the flavor of the season. Especially, yeah. And it is pretty important, you know, for us, it just helps. And I know our state vet really appreciates getting that additional information as well.
Yeah, you put a lot of stock in that with the papers that have come out showing that the same sample sent to different labs will have different titers as different serovars as the highest. Like, do you really take that and believe it?
Yeah.
I guess I haven't necessarily. But
yeah, not necessarily, JD, but certainly some of them, and we've had them come in where they're negative, and you know, the convalescent, we get a 1 to, I don't know, our highest one was like 1 to 150,000. Believe that, and we always use the same lab, so we don't have that lab to lab variation. If they're close, you know, no, then it's anyone's game as to what multiple ones are reading high. But I mean, we've had some outstandingly high titers, and I would feel pretty confident in those.
Okay, interesting.
Interesting. And how do you interpret the cross reactivity between serovars, like in deciding like what the flavor of the year is?
Yeah, I haven't a clue when it comes to that, unless we have a large spread between the two. But you know, you get a 1 to 1,600 and a 1 to 1,200. No, I don't think you can distinguish between those two.
Yeah. Okay, cool. I like it. Well, let's move on to our second paper. So this study I was super excited to see come out. Tony, the primary author, was an intern when I was a resident. She definitely was the most calm intern of all. So I'm excited to see this paper from her and the Tufts team. So this paper specifically is looking at dogs that require renal replacement therapy. So introduction wise, there's one main other study we have that looks at outcome of dogs with lepto, and a survival rate of 86% was reported in dogs with AKI due to lepto that required intermittent hemodialysis. But overall, the outcome of dogs with AKI secondary to lepto that require dialysis is pretty poorly characterized. Some earlier studies that mainly focused on dogs treated medically that didn't necessarily need or have access to dialysis did report severe azotemia as being associated with poor prognosis. And in general, we have some rough stats that about 30% of dogs with acute lepto are going to become oliguric or anuric. And these are the dogs that we need an expanded window of recovery because they might die, but potentially like they can still recover if they're given the chance. And that's where renal replacement therapy is going to be vital to remove uremic toxins, correct fluid and electrolyte disorders, restore acid-base balance, and really just give us more time so that we can institute antibiotics and wait for the recovery phase to begin. So this was pretty cool since kind of this initial study was back in 2000. So super awesome to kind of see what's going on right now. The primary aim of the study was to look at survival to discharge as well as short-term, so under 30 days, as well as long-term, over 6-month outcome in dogs with AKI that required renal replacement therapy due to lepto. A secondary aim was to see if the maximum BUN, creatinine or bilirubin, or the number of body systems affected was associated with survival to discharge. This study was a retrospective study that included dogs with lepto that had AKI that needed renal replacement therapy, and it was over a 3-year window from 2018 to 2021, conducted at Tufts. Inclusion criteria: dogs had to have a complete medical record, a confirmed diagnosis of lepto, and they did need at least 1 session of renal replacement therapy. In this study, diagnosis of lepto was based on a single MAT over 1 to 800, if it was a serovar not included in vaccines, or a single titer over 1 to 1600 for vaccine serovars, or kind of consistent convalescent titers, or a positive PCR, whether that's urine or blood. Dogs were excluded if they didn't have complete medical records, if they weren't diagnosed with lepto based off the above criteria. So that would be like if they just had a positive witness test, for example, like they couldn't be included, as well as dogs with lepto AKI that didn't need renal replacement therapy. So dogs with confirmed lepto had all of their medical records reviewed, and ultimately kind of patient data was extracted from the medical records, all of their CBC biochem and UA data within 24 hours of when renal replacement therapy was initiated was reviewed, and throughout the hospitalization period, the maximum creatinine, BUN, bilirubin, and the minimum platelet counts were determined based off medical record review. And to note, these patients may have had a range of these additional tests performed, including urine culture, coagulation testing, other infectious disease testing, imaging. In terms of specifically leptospirosis testing, so point of care screening tests were performed on some of the patients. Acute and convalescent MAT testing was performed, and these were the serovars on the panel at the testing lab. PCR and blood and urine was also done, but confirmation was based off the MAT and the PCR testing only. So in terms of if patients were candidates for renal replacement therapy, so they naturally had to have a documented AKI, and then similar to kind of widely accepted recommendations for dialysis, They either had oliguria, anuria, hyperkalemia, fluid overload, or progressive azotemia despite medical management. Pretty much all of the dialysis stuff is all fairly consistent with accepted protocols. So dialysis catheters were placed either under sedation or general anesthesia. Dialysis was performed on a intermittent dialysis platform on the Fresenius unless that machine wasn't available, and then the Prismaflex was used. Most of the dogs did have unfractionated heparin, systemic anticoagulation, but citrate was considered if there was clinically significant thrombocytopenia with under 60,000 platelets. The prescription for dialysis was adjusted based on the needs of the individual patients. Session records were reviewed for complications, which were categorized as either they didn't require intervention, they required emergent intervention, or required urgent session termination. In terms of the body systems affected data, so this was determined based on evaluation of blood work, UA, coag testing, imaging, and clinical signs. Renal involvement was determined based off our IRIS AKI grading scheme. Hepatic involvement was defined as elevations in 2 or more liver enzymes, plus or minus hyperbilirubinemia. Pulmonary involvement was defined as persistent tachypnea and dyspnea, and they had to have either evidence radiographically or on necropsy of lung disease. Coagulation system involvement was defined as abnormal coag testing before renal replacement therapy, clinically relevant thrombocytopenia, or clinical evidence of thrombosis or hypercoagulable bleeding tendencies. In terms of the outcomes, so survival to discharge was assessed based off if dogs were alive at hospital discharge. The serum creatinine was recorded at this time for the dogs that survived. For the dogs that didn't survive, it was recorded before time of death. Assessment of short-term survival was defined as under 30 days. Long-term survival was 6 or more months. And that was performed based off review of medical records, both from Tufts as well as primary veterinarians. Dogs that were alive after 6 months from discharge were also staged according to IRIS staging. In terms of going through the results for this study, so 24 dogs received treatment with renal replacement therapy for lepto-AKI. 2 dogs without confirmed lepto were excluded. Out of these dogs, 64% were males, 36% were females. Our average age was 5.1 years and then 14 kilograms for body weight. And there was a range of different breeds included, with the most common being mixed breeds and then these listed larger breed dogs. In terms of lepto testing, so the witness test was performed on 3 dogs, the SNAP test on 5 dogs, acute MAT on 20 dogs, convalescent on 7, and PCR on 15. The highest titers on MAT in the study is going to be for these 2 listed Ceravars. So moving on to the results, so 21 dogs were specifically referred for dialysis, and before referral, like all of these dogs were hospitalized at another hospital, which makes sense. And the median time of hospitalization before referral was 2 days with a range of 1 to 4. So we can see if these patients need it, they get referred pretty quickly. Clinical signs on presentation, vomiting, anorexia, lethargy, smaller proportion had diarrhea and weakness. Physical exam findings, we can see almost half were icteric. About 20% had respiratory signs, 30% had peripheral edema. We can see that in terms of hydration status, about a quarter were dehydrated, but still a big proportion at 60% presented fluid overloaded. And this probably correlates to the median blood pressure being 156. We can see a big range, but a number of these dogs were hypertensive. On intake, 30% of dogs were anuric, 36 were oliguric, 23% were polyuric, and 9% of dogs had normal urine output. So this table describes some of our clinicopathologic results from dogs with lepto that needed dialysis. So we can see important things to note, like all of the dogs are azotemic, which kind of is based off the design of the study. And going to this next slide, we can see that anemia was present in a number of the dogs, and out of those dogs, kind of half of them did require blood transfusions. Going to our azotemia, the median maximum BUN and creatinine was 159 BUN and 9.8 creatinine. So this worked out that 55% of dogs had a grade 4 AKI, and then 45% had a grade 5 AKI. 82% of dogs had elevations in liver values. And on intake, 64% of dogs were hyperbilirubinemic, with the median bilirubin being 2.5. However, in hospital, kind of after a median of 3 days, the bilirubin did increase to a median max total bilirubin of 8. The median minimum platelet count was 97, but that was a big range that went from 22 to 264. And we can see it's pretty uncommon that dogs will have a platelet count under 60,000. So that's helpful to keep in mind. Out of the dogs that had coagulation testing performed, 40% had a prolonged PT, 80% had a prolonged PTT, and out of the dogs that had a TEG performed, 3 were hypercoagulable and 1 was hypocoagulable. In the dogs that had UA performed, we can see proteinuria, glucosuria are fairly common. Less common will be pyuria and bacteriuria. We can see only 4 dogs had a UPC performed, with the median being 1.7, and 27% of dogs had a positive urine culture, whether that was on admission, but more commonly it was during hospitalization. In terms of extracorporeal therapy, and the results with that. So indications for dialysis, the biggest one was inadequate urine production for 73% of dogs. We can see that overhydration was sadly pretty common as well at 59%. Hyperkalemia a little bit less common at 45. For the dogs, we can see that 91% had heparin, whereas 9% were performed with regional citrate anticoagulation. In terms of the number of dialysis sessions per dog, and this I think is super helpful in terms of when kind of having conversations with families in terms of how long are we committing to dialysis for. We can see there was a range of 1 to 8 sessions per dog, but the median was 3 treatments. For complications in those treatments, we can see in this population 32% had complications that didn't require intervention. 18% had complications that needed emergent treatment, and 15% had complications that required treatment to be urgently terminated. And the reasons for that included was severe arrhythmias, followed by concerns for disequilibrium and agonal breathing in 1 dog. But no dogs died during the sessions, which is awesome. In terms of the body systems affected, the number affected per dog in 14% was just 1 body system, 2 body systems in 36% of dogs, 3 in 27%, and 4 in 23%. By definition of this study, all dogs had renal involvement. And I think important to note that kind of half of those dogs had abnormality on imaging of their kidneys, but the other half had normal appearance. So important to keep in mind. Hepatic involvement was present in 73% of dogs. And of those, 9% had abnormalities on hepatic imaging. That's kind of helpful to know as well. So for body systems affected, 9 of those dogs did have respiratory involvement. And then 54% had coagulation system involvement. Moving on to the survival data, so 73% of dogs survived to discharge. So this is a little bit lower than what was reported in the study that looked at kind of having an 86% survival. The median serum creatinine at discharge for survivors was 2.2. And 12 dogs, or 75%, were still azotemic at discharge. Causes of death in non-surviving dogs was reported to be either cardiopulmonary arrest or euthanasia, about 50-50 for each. Reasons for euthanasia did include either persistent anuria with respiratory distress, progressive hyperbilirubinemia and concern for DIC, or persistent anuria unresponsive to treatment. I thought was interesting, before death, 3 of those dogs did have normalized urine output, but serum creatinine was still pretty high at 7.2 for the median, with a variable range. In terms of the median maximum BUN, that was not significantly different between survivors and non-survivors. And this was the same for the maximum creatinine. So this really refutes, at least in this population of dogs, kind of the earlier data that was suggesting that azotemia was related to outcomes. So important kind of for us to spread awareness that patients shouldn't be condemned based off their azotemia. Certainly equal chance of surviving or not just based off that. What was significant though was the difference in total bilirubin between survivors, where it was a median of 1.9 versus non-survivors having a median of 21. And here we can see they kind of categorize the number of body systems affected. So we can see in dogs that survived, higher proportion just with 1 or 2 body systems versus those that didn't survive. Kind of a lot of them had 4 body systems affected. So kind of helpful to keep in mind as we treat these patients. There was a significant difference between survival and the number of body systems affected, as we talked about. So this is kind of shown in a different manner via the figure here. So kind of as we mentioned about higher number of body systems in the dogs that didn't survive. This figure kind of shows a nice representation of what we have talked about in terms of BUN and creatinine. We can see there's massive amount of overlap in terms of dogs that survive and dogs that didn't survive. Whereas bilirubin, we can see is certainly vastly higher in dogs that didn't survive versus those that did. In terms of the short-term outcome, so out of the 16 dogs that were discharged, only 3 dogs died under 30 days from discharge. And causes included like just general declining condition, sudden death and progressive azotemia, and none of those dogs did have a necropsy performed. So we can see that if we discharge a dog, like most of them are going to stay alive, which is good. In terms of the long-term outcome, also good in that kind of 13 dogs that survived over 30 days from discharge, kind of most of those were also still alive over 6 months from discharge. 8 dogs were alive at the time this paper was written, and they were staged based off their IRS-CKD stage. And we can see 5 of those dogs were stage 1 and 3 dogs were stage 2. With the median serum creatinine being 1.3. Creatinine normalization occurred in 50% of the dogs, and this is a little bit lower than what's been reported previously in Dr. Sagiv's study, and this might be related to the fact that this study looks specifically at lepto and in patients that need renal replacement therapy, also in a different geography in the world as well. So I think a little bit hard to kind of compare. What was a little bit unclear to me was, so when the paper was written, 4 of the dogs that weren't alive were euthanized due to suspected kidney disease. Was unclear kind of the definition of that based off like serum creatinine wasn't available prior to them being euthanized. So I found it a little bit hard to kind of follow in terms of that suspicion, but I'm assuming they had kind of chronic kidney disease or other factors that were leaning us towards that being their reason for euthanasia. The limitations for this study, so retrospective, fairly small cohort of dogs, diagnostics weren't standardized, as well as kind of long-term follow-up. And what I thought would be a little bit tricky would be distinguishing clinical signs and whether they're due to uremia versus fluid overload. And such in terms of like working out the number of body systems affected. For example, the dog I have now like did have a lot of GI signs, had pancreatic edema and such on ultrasound, but was massively fluid overloaded, and that component was fixed within kind of 2 days. So it's hard to know, like, if we remove that component and those body systems, like how does that impact versus a dog that has like true pancreatitis, like from the lepto directly, which I think would be pretty hard to figure out in a study in general. So just something kind of I started thinking about there. I think for veterinary studies in general, it's always challenging that owner finances comes into play. So it's hard to know how much did that affect survival to discharge, but certainly the dogs that were euthanized sounded pretty severely affected. So it's hard to know what was their reason for euthanasia. One thing I'll comment on, I couldn't see, maybe I missed it, but I couldn't see the vaccination status of dogs reported in this study. And then kind of commented on kind of reasons for long-term survival and euthanasia. So in conclusion, I think from this study, the big takeaways is that the severity of azotemia does not predict outcome. So we shouldn't prognosticate based on that. Overall, like dogs that are severely affected with lepto requiring dialysis, they still have a pretty great survival to discharge. So no reason not to try based on it being severe. Some possible correlations to think about is going to be when there's multi-organ involvement and hyperbilirubinemia, potentially we might have a worse outcome. And yeah, that's pretty much my big takeaways from this study. So I thought it was pretty awesome, and I'm excited to have authors of the study on this call. That's all I have. It's a bit of a whirlwind. I bit off a bit more than I could chew while doing a dialysis patient, but hopefully that was helpful.
That was great, Mandy. Awesome review, and piling in not one but two papers into the session was great. Questions or comments? We have, as Mandy said, some of the authors that are here with us as well. Any comments or anything else people like to share? Are folks experience treating lepto patients that are need of extracorporeal management similar to what the paper showed? Anybody have some contrasting experiences? We're pretty lucky with our patient population. We don't see a lot of pulmonary hemorrhage associated in those patients. So that is not something that we see, but I certainly could be something that could make those patients a lot sicker, a lot more challenging to deal with. It seems like maybe it has some regionality to it. I don't know if there are any folks, certainly in Europe, they see a lot more of it, but here in the US, anyone seeing a lot of lepto with pulmonary hemorrhage involvement?
Not since I moved east. We saw a couple in Seattle.
Okay.
I have the feeling that we are starting to see some of them, but it's still for sure very rare. I would say perhaps one dog out of 10.
Wow. I would say we're probably just one or two dogs that I can remember, period. So we're pretty pretty minimal. Southern California, 2 lepto patients in the last 4 weeks that Ashley said, but neither had pulmonary hemorrhage, so that's good. I don't know how much of it could be serovar related or just severity of disease or pre-existing lung disease. You know, I'm happy that we don't see a lot of it, because those patients are just that much more challenging to manage.
And I think the group in Bern is working on it and trying to find why some of them are developing that, but it's still definitely a big question mark. And what is awful is how dynamic all this situation is. And you have the feeling that no matter what you try, we have some of them that are doing well and some of them that crash and burn. and we have no idea why one did differently than the other one. So it's a very frustrating situation.
I find it to be so frustrating when they have renal recovery, but then it's other organ systems that prevent them from leaving the hospital. That is just the biggest bummer in the world when they've graduated dialysis, but they have we've had them have horrible GI disease, horrible liver disease. We've had them have systemic vasculitis where they're just so close, but then their quality of life is just still affected. And those are the ones that are just such a sad case because the team has worked so hard to get them to that point, and they're so close, and they don't turn around. And that's such a bummer.
And this is 100% the reason why we decided to write this article, because, probably another patient that we lost for something else, and we were so frustrated. We wanted to prove that we can definitely lose them from something else, and we shouldn't give up on them. But for sure, this other system involvement can be the death sentence at the end. And it's the worst. I 100% agree.
Yeah, that really sucks. I have just a couple somewhat related questions. What's your experience with using Vet Rescue? Because I know in this paper there was just one patient that had it added in circuit for dialysis, but I know you've been maybe doing another study on that. I was interested to see what your experience with that is so far.
Yeah, that's another study, and we're analyzing the data now. So yeah, keep waiting. We'll let you know in hopefully a very short period of time. We can say you can safely use it. And one of the things you do need to be cognizant of, I can share, is we tend not to use it if their platelet counts are really low.
Do you have a cutoff for that you recommend? Because the patient, I did use it in the second treatment on my most recent patient, and the platelet count was 80,000 that day, but then the next day it had gone down to 30,000, which maybe was related to the column versus the lepto. So I wasn't sure what your experience with that has been.
It kind of depends a little bit on where they're starting off, but in that 70 to 80,000 range is where we'll be hesitant to use it, and we probably won't use the column there.
And we've definitely seen a drop like that from the column. So yeah, I wouldn't be surprised if it's related to that.
Okay, that's good.
And they usually, 3 late days later, they may have rebounded enough that you could feel like, well, do I want to risk it again? But until we see overall the efficacy of the column, I mean, that's what our study is looking at. So hopefully that'll be able to shed some light on that.
Yeah, I love that. And then my other thought was, I was reading like some of the human literature on TP use in lepto cases. It seems like for our patients, it's mainly considered if there's pulmonary involvement with lepto, but I'm not sure if anyone has incorporated TP into their lepto treatments so far.
I think maybe Terry and Arian might have used that as part of their management in some of the patients with the pulmonary hemorrhage, with the consideration that maybe it was immune complexes affecting the alveoli, almost like a good pastures type syndrome. I can't say that we have, and every time we have a case that might have vasculitis or some other systemic signs, I end up pulling the few case series that are there and people just looking at steroids with lepto, and the case series are very they're quite opposite. That there are some case series that show positive effect of steroids on survival, and other studies that show no improvement on survival when you add steroids. And there has not really been a good large-scale randomized study of leptospirosis in people where steroids could help. So it's one of those things that we've thrown at patients for other systemic signs when it seems like we don't have any other options. but I haven't necessarily jumped to TPE in those patients along the same line.
Yeah. Okay. Interesting.
And I appreciate the last comment, like we also tried to emphasize that in our article, to emphasize the fact that it was a very specific population, not only of AKI secondary to lepto, but cases that had access to renal replacement therapy. Because probably the outcome of this population would have been 0% discharge without access to that. So for sure, BUN and creatinine for this specific population was not an indicator for survival, but that could be one if they don't have access to renal replacement therapy.
Yeah, very true.
I think that's a very good point to remember when we're training particularly our students and interns going out, is that they tend to panic when the creatinines are like 5 and 6. And when they start seeing numbers in the 13 range, it's like, let's euthanize, there's nothing to do. So often, if there isn't referral centers available, people may bail out a lot sooner than even trying some of the more conventional medical management that would have been used in the past. And I think in that one paper, if I remember, that came out of Davis years and years ago, there was still like a 60% survival to discharge when they looked at their overall lepto population versus managed with medical management versus dialysis.
And to answer your question, none of them were vaccinated, unfortunately.
Yeah. Okay, that makes sense. I assumed as much, but figured something to ask. But that makes sense.
And some of them were not vaccinated because the vets told them to not vaccinate them because of the vaccine reaction. So that was the saddest.
Oh, sad. That's so sad. In the Northeast.
And equally sad is some of them have come in at 10, 11 weeks of age, which would say the maternal antibodies weren't there either, so bitches haven't been vaccinated.
Yeah, okay, makes sense as well. Cool. Well, I appreciate everyone chiming in and chatting and giving their perspective.
Thanks, Mandy. That was great. Really appreciate all that. And thanks to the authors that are on the call too for doing the research and putting it out there. That is a great paper and really appreciate that. And it was a great round session.
Nice job of presenting it all, Mandy.
Oh, thank you. I would have liked to be more prepared, but the last few days I was in the hospital like 14 hours. So I was like, it's relevant if nothing else.
Awesome. Well, our next Journal Club session will be on May 21st, and that will be at 12 noon Eastern time. So we'll keep checking the website, the acvnu.org for the articles, and I'll post on the ACVNU listserv and update as well too. So look forward to seeing everybody at the next one.
Sounds good. Thanks, everyone. Have a great day.
Thanks, Mandy.